We will continue with Part 4 of Module 3 of Alterations of the Endocrine System. Hyperglycemia diabetic ketoacidosis is also referred to as DKA. It is exclusive to type 1 diabetes mellitus. Onset is sudden. Glucose is unable to enter the cell due to the lack of insulin, causes cell starvation, and then the body initiates glucogenesis by breaking down proteins and fats, which equal ketones. This excessive acid leads to a metabolic acidosis. The etiology of DKA can be from increased intake and too little insulin, or it can be from surgical stress or stress emotionally and/or infections. The only way to prevent DKA is to have a tight blood sugar control. DKA clinical manifestations include vomiting, weakness, drowsiness, lethargy, blood sugar that is elevated 300 to about 800. They may have a fruity odor of breath and urine. They will have large urine output. Glucose and ketones are present in the urine. They may have Kussmaul's respirations, polydipsia, and or even dehydration. So how are we going to treat DKA? Well, we're going to make sure that there is IV patency with fluids. We're going to monitor vital signs. We're going to monitor the intake and output. We're going to monitor electrolytes. And then there's going to be a steady administration of the regular insulin IV. And then we're going to check finger sticks every 15 minutes. Now let's talk about hyperglycemic hyperosmolar non-ketonic syndrome, also referred to as HHS or HHNK. This occurs more frequently in elderly type 2 diabetes mellitus. It's due to similar causes of DKA in the IDDM. There is gradual onset. Blood sugar is usually 800 to 2000. Mortality rate is 65%. There are no ketones that are formed and no acidosis is a result. Often it is misdiagnosed as a neural problem that is related due to the decreased in level of consciousness. Clinical manifestations of HHS are dehydration, decreased in LOC, and then hypotension and or tachycardia. We will treat the patients with fluids, an insulin drip, and then we will support vital functions. Okay, so let's discuss some chronic complications of diabetes mellitus. These chronic complications can either be microvascular or macrovascular. Microvascular, the patient will experience retinopathy, neuropathy, and nephropathy. For macrovascular, the patient will experience cardiovascular disease and cerebrovascular disease. Okay, for the microvascular, we're going to discuss retinopathy first. Retinopathy is a damage of the retinal vessels. It may lead to blindness. Patients with diabetes mellitus are recommended to get a yearly eye exam. Retinopathy is generally linked to fasting blood sugars that are above 129. Another microvascular complication is neuropathy. Neuropathy is caused generally because hyperglycemia equals nerve hypoxia. And it may involve widespread nerve function loss. Generally, patients will have a numbing, tingling feeling either in their fingers or their toes in the beginning. Generally, it starts in the feet. As the disease progresses, it can become generalized throughout the body. The last microvascular complication we are going to discuss is nephropathy. Nephropathy occurs due to damage to the capillaries in the kidneys. And due to this damage of the capillaries, they develop an increased permeability and begin to leak red blood cells, albumin, and protein into the urine. The earliest sign of nephropathy is the microalbuminuria. Diabetes mellitus is one of the leading causes of end-stage renal disease. Due to neuropathy, patients experience the numbness in their feet or their hands, but generally in the feet, which puts them at a high risk of getting sores or open areas or wounds that cannot heal. So we are going to discuss diabetic foot care. You will need to teach the patient to visually inspect their feet daily and to use a mirror if needed to see the bottom. You want to encourage them to use warm water, not hot water, because this could lead to burns that could not heal and they don't really feel the water being too hot. And you want to teach them to avoid soaking because then it can cause cracking of the skin. Educate the patient to make sure that they dry their feet thoroughly. You want to teach them to use mild lotions and make sure that they don't put it in between the toes. Have the patient make sure they cut their toenails straight across. Remind them that corns, calluses, and ingrown toenails should be treated only by a podiatrist. Encourage the patient to wear cotton socks and to make sure that they change their socks daily. Educate the patient to wear well-fitted shoes and to never go barefoot. Remind them to elevate their feet when possible to help assist in circulation. And then remind them to wear socks to bed and to never use a heating pad. Okay, so now we are going to discuss macrovascular complications. The first one we're going to talk about is the cardiovascular disease. A patient with diabetes mellitus is 2 to 3 times greater risk for cardiovascular disease than a non-diabetic client. They had the potential for atherosclerosis, which causes about 80% of the deaths in clients with diabetes mellitus. And then 75% of hospitalizations are for diabetic complications. They may have a myocardial infarction leading to the cause of death among diabetes mellitus clients. They will have a left ventricular dysfunction. They can have fatal dysrhythmias. They could have heart failure. And it occurs in up to about 50% of our diabetic clients after they've had a myocardial infarction. The other macrovascular complication is the cerebrovascular disease. It puts the patient at risk for stroke. Damages to the cerebrovascular arterial circulation is caused by diabetes mellitus. Elevated blood glucose levels at the time of stroke can lead to a greater brain injury and a higher mortality rate. This concludes this lesson of care of the patient with diabetes mellitus. If you have any questions related to the lesson content, contact the instructor.